semoga acara hari ini dapat membawakan knowledge baru di dunia neonatologi.
So it's predictive intelligent control of oxygenation. Yeah, so actually the most common drug that we give to our patients in neonatal ICU would then be oxygen. Yeah, because studies have shown that for preterm infants, actually 95% of them receive supplemental oxygen. Yeah, and then while this, like if we give too little oxygen to them, it leads to direct or indirect cellular damage. But then if we give too much oxygen to them, it actually causes oxygen toxicity and also eventually lead to BPD and also retinopathy of prematurity, ROP. So there is this drug that we give very common, but and it causes issues to our babies if we do not give them enough or we give them too much. So therefore in the NICU, we monitor the patient's SpO2 a lot, okay? So not just during recruitment maneuvers, but as a routine monitoring, we also monitor their pulse saturation, because this is a non-invasive way of seeing how good their oxygenation is instead of doing a lot of arterial blood gas for them. Yeah. So, however, with this monitoring, right, it's not easy for us to maintain their SpO2 within this target, because their lung conditions always changes, their breathing pattern also change, and also the procedures that we do, like suctioning, will also cause the SpO2 to actually change also as well. So, therefore, you can see that ventilators, right, we are developing this thing called a closed-loop control of oxygenation. So which is based on the patient's SpO2 readings. The ventilator will change the FiO2 readings itself to make sure that the patient's SpO2 is within the range. So you can see that yeah, so there is a question that is highly debatable, whether you want to set a low SpO2 range or you want to set a high SpO2 target. Okay, so but then studies have shown that if you set a low target of 85 to 89%, it increases the patient's mortality and also increase the risk of necrotizing enterocolitis. And also the high target will then cause retinopathy of prematurity. So therefore, the AAP and suggested a range of 90 to 95%, whereas for the European guidelines will suggest a range of 90 to 94% target. Okay, so for you, how do you all practice in your NICU? What target do you set? 88 to 92. Is it? Or do you follow the American or the European guidelines 90 to 95? 90 to 95? Okay, yeah, so yeah, but then we do know that setting a range here is difficult. Yeah, because it's always out of range. Yeah. So yeah, so you can see that patients, right, a lot of times at below the target range or above the target range. So studies have shown that I think a percentage like 9 to 11% is less than the target of the 85%, and then like up to 33% of the patients, right, are above 95%, okay, in certain times. So it's actually really very difficult to make sure that the patient is within the optimal SpO2 target that you have set. Okay, yeah, so you can see that also this is because patients, especially when they are premature, they have frequent episodes of intermittent hypoxemia. Okay, so these are very prevalent in those who are on prolonged mechanical ventilation. Yeah, this is because whenever that they have some active exhalation, their tidal volume is reduced, and then their lung capacity is not that good, and then in the end you will impair their lung mechanics and then go to hypoventilation, and then they have transient intermittent hypoxemia. Yeah, this is their breathing pattern, so a lot of times their SpO2 fluctuates a lot. Okay, so some strategies that we do to prevent this kind of intermittent hypoxemia, right, is that we might be setting a higher PEEP for the patient, positive and expiratory pressure. Okay, because PEEPs help to increase the lung volume. So just now we did say when we do recruitment maneuvers, we increase the PEEP, we increase the lung volumes, and then we increase their compliance. And then from there, we are able to help with their oxygenation. But then this maneuver of increasing PEEP is maybe also partially effective if it's caused by active exhalations. Okay. Then also we might set a higher PIP for them, okay, because higher PIP, then we will give them higher volumes also as well. Then from there, maybe we can help to expand the patient's lungs, okay. But then when we give them too high PIPs, might not be good also, yeah, because it might cause lung damage to them. And also another thing is that when we want to improve hypoxemia, can also be helping them with their asynchronies. Yeah, so make them more synchronized with the ventilator. We can also help with the reduction of this hypoxemia for the preterm infants. Yeah, so I think there was ventilator graphics that actually was teaching us how to see asynchrony in the babies, right? So with the asynchronies, we are actually causes this kind of intermittent hypoxemia. And also another thing that can help with this intermittent hypoxemia is volume guarantee. Yeah, so volume guarantee helps to maintain a set tidal volume for the patient. And then this increase in ventilation and will actually help this kind of intermittent hypoxemia also as well. Okay. So also another thing that we most of the time we do when the patient has hypoxemia is to give them oxygen. Yeah. So you can see that this is how a caregiver, when the patient's SpO2 decrease, okay, they will increase the FiO2. Okay. So but you will see that end up, right, they will maintain the higher FiO2 for the patient, and you see that the patient's SpO2 is a lot higher than the target that they have set. Yeah. And then, but then because when we give them too much oxygen and too high FiO2, yeah, then this will then expose them to all this hyperoxemia that is happening now. Okay, so then later on, if the patients desats again, then you will see that we will actually increase the FiO2 to even higher to actually compensate for this desaturation. So in the end, we might be giving a lot more oxygen to the patient unknowingly, yeah, to maintain a high SpO2 for them. Okay, so fluctuations, yeah, there is fluctuations in your SpO2 increase with postnatal age and progressive chronic lung disease. So for this, right, you can see that if here there is this study that they show that when they actually have patients that is, let me see, so if they have a patient with nurse, okay, to patient ratio 1:1, the number of times where the patient is within the SpO2 target is higher, as yeah, within SpO2 range is higher, and then when it's too much oxygen is much lower. Okay, but when there is one nurse to 3 patients, which is it common here in Indonesia? Yeah, 1 nurse to 3 patients, or even more, is it? Yeah. So you can see that when the nurse to patient ratio is higher, the times where it's within the target range is actually much lower, and patient is given more oxygen. Yeah, because they don't want the SpO2 to drop too much and alarm. So they will give slightly more oxygen. Okay, which is understandable because they are busy. Yeah, but then not good for the patient, right? Then one more thing is even more interesting is that after you teach them, okay, you see that their time within the target range, right, actually increased, okay, after education. But then when the time with the SpO2 more than target range actually reduced, okay, but time with SpO2 less than target range increased. Okay, so they actually prevent hyperoxemia, but now there are more hypoxia coming in. Yeah, so giving them education maybe is not so good also as well. Yeah, but there's a reason behind this. Okay, yeah. So here, that's why because SpO2 is difficult to maintain within the range, ventilators actually come out with this automated control of FiO2 on the ventilators itself to actually help with the doctors as well as the nurses to troubleshoot this SpO2 reading on the patient to make sure that it's within the range that you have desired for them. So you can see that like Avia Clio, that's one of our ventilators here that has closed loop control of oxygenation. Then we have this one is Oxygenation on SLE 6000. Then we have PRICO on our Fabian, which is what we are talking about today. Then there's also the SpO2C in SOFI ventilators that has this kind of software for closed loop control of oxygenation. Yeah, so with this, right, it helps to decrease the workload of nurses so that they don't need to keep troubleshooting. Okay, and then this is just clinical studies that is done, I think is a paper by Prof. Dani. Okay, so actually he did a lot of research for us, but you can see that Clio is one of the first closed loop controls, FiO2 software being installed in the ventilator to help with the control of FiO2 for the patients. Okay. Then here is just the main results of the studies. Okay, so it's just saying that I'm not too sure why is this not showing that well, but this one is showing better. But it's just showing that after we use the automated control, right? Okay, we are able to set in the the SpO2 range that you have set more often. Okay, so we are within target for a longer period of time. And then also we are able to reduce the chances that patients are being given too much oxygen. Okay, but however, closed loop controls are not very good in preventing hypoxia. Okay, because you can see that hyperoxemia, the only reason is because you prescribe too much oxygen to the patient, right? So the ventilator can solve by reducing it. But then if you have a patient that maybe has desaturation, okay, because of secretions and all this, the ventilator can increase the FiO2, but it cannot solve the original problem of the patient having hypoxia. So that's why this kind of closed loop controls is good, yeah, but then we still have some drawbacks that is not able to help patients with hypoxia. Yeah, so it's important for for everyone to know that, okay, automated are very good, it helps. Yeah, but then automated still has some drawbacks to it. Okay. So yeah, so this one is just talking about just now what I was explaining about how we can reduce the times with that patient is being hypoxia and also patient that is reduced, okay, as compared to manual control. If you were to change by yourself, we are not in the range for most of the time. Okay.
Sorry, yes. Mrs. Hui Lin, 5 minutes more.
Oh, 5 minutes more. Okay, okay, very fast. Okay, then here, yeah, so this one is also the same, and we talk about less. So this one is another study that was using our PRICO ventilator to actually look at cerebral and splenic oxygen when they are using automated control of inspired oxygen FiO2 in preterm infants. Okay, so study has shown that we are a lot of times when we are using this PRICO, we are able to make sure that the patient's SpO2 is within range, and then the oxygen for the cerebral and splenic oxygenation is good. Okay, yeah, within the range that we wanted. Okay, and then yeah, this one we can skip. Okay, then again, this one is another study that shows that when we use this this closed loop control of oxygenation, it actually helps with the patients, and also yeah, so this one is here. Okay, so what it helps, what is not good, okay, not good, but what remains the same is the patient's mortality. Okay, we use automated control of oxygenation, but what improves is that we actually have a lower ventilation days when we use automated control of oxygenation. And also one more thing that is better is that there is a sign that there is an increase in number of using of NIV for the patients on CPAP and high flow nasal cannula. So which means that patients is not ventilated on ventilators that for a longer period of time, okay, which causes prolonged weaning. But we actively weaning the patients faster when we actually use closed loop control of oxygenation to set the FiO2 for them. And using more NIV is good for them, okay? So just to share, I think in Singapore Hospital KK, they actually are moving a lot more patients from invasive to non-invasive ventilation. Yeah, so like I think about 50% of the babies in the NICU in KK in Singapore is actually using NIV. And then only the very sick ones, then they will intubate. So now first line that they do for the patients instead of putting onto intubate them, they actually do non-invasive for them now like more often. Okay, so then also here is talking about intermittent hypoxemia or bradycardia and late death. Okay, so actually with this intermittent hypoxemia, actually the probability of this bradycardia and late death is actually higher. So that's why we try to prevent this kind of intermittent hypoxemia from happening. Okay, so but then if the nurses are too busy, nobody will be able to change the FiO2 for the patients, and then the patients will have a higher risk of bradycardia or late death or disability, okay, in the future. Okay, so this is just what is PRICO, and then yeah, talking about how our algorithm works. So here on the ventilator, you will be able to set the low target and also the high target here, SpO2 target. And then if your SpO2 is within range, your ventilator here will automatically either increase or decrease by 1% or just leave it at 0, okay? If the patient's SpO2 is within target range, change the FiO2. But then if it's out of the range, then the changes in the FiO2 will be bigger to make sure that it's within the target itself, okay? So here, PRICO for itself, we can be used in all types of ventilation modes, invasive and non-invasive also as well. So not just invasive patients that is put onto ventilator, you can also use non-invasive, okay, for them to do PRICO titration of the FiO2. Okay, so this is the accessories that you can use with PRICO, okay, just a cable that is attached to the ventilator, and then the SpO2 probe, okay, attached to the baby. And then here is ventilator will show you the perfusion index. And then here is how it will, you can turn on, set up, okay, so this one we will do it during hands-on, so you can take a look at it. And then this is how you set the sensitivity also as well. And this is about fast set, also part of the things that we can do. And then here is the averaging time. Yeah, we can talk about this during hands-on. Okay, so here you can see that what we can set here is the SpO2 target. So you can set 90 to 95 for the patient, and then what FiO2 that you allow the ventilator to go up to. So what is the minimum FiO2 that it should be going, and what is the maximum? Okay, so one question also, what do you think is the maximum FiO2 that you will give to the patient, and you will think that it's dangerous already? 65? How many? No right or wrong question, just your practice. Yeah, what you feel. How much is too much? 45? 40? Yeah. So if you think that whatever that you think is too much for the patient, okay, so you can set the maximum here, okay, the percentage. So that if it hits the point that you are uncomfortable with, then the ventilator will alarm to tell you that I'm at the maximum FiO2 already. Please come and check me. Okay, but otherwise it's within the range that you feel that is safe. It will still be automatic going through the titration of the FiO2 for you. Okay. Okay, so this is just the settings. Yeah, so later on during hands-on, we'll just talk about it. Okay, yeah. Yeah, so again, this is just the algorithm. We will just change the FiO2 maximum every 30 seconds, okay, to see how the patient responds and also the SpO2 readings before changing again, so that the changes will not be that fast, okay? And then the steps will be based on how far the patient is away from the target, and then they will change by 1 to 10% based on how far the patient is away from the target, so that it's not adjusted too quickly or too slowly for them. Okay, so one more thing is on our ventilator is that we will do safety checks to make sure that the signal stability of SpO2 tidal volume and also your percent leak is in the correct range. And then from there, you can do the safety checks, and once it's okay, then they will do the FiO2 adjustment. Okay, so it will actually do some safety checks before it does the FiO2 adjustment. In case it's not a correct reading, it's not going to give you a wrong adjustment for the patient. So it's actually quite safe, okay? And because also there's a lot of alarms that you can set for the patient. So based on what you want to set for each patient, you can set accordingly. And the ventilator will alarm for you to come over to actually check on the patient itself. Okay? So if it's patient too much oxygen, they will also alarm that there's a high SpO2 alarm also as well. Okay? So this is just a summary. So PRICO, right, it actually continuously monitors the patient's SpO2 and adjusts the oxygen accordingly. So it's the same as Avia Clio also as well. Yeah, we do automated changes in patient's oxygen based on their SpO2 readings. And then so that with this, right, patient will be able to spend more time in the SpO2 range that you have set. And also reduces the time that the patient is hyperoxemic, and also if in cases that the patient is hypoxemic, severe hypoxemic, PRICO also helps to reduce the risk of oxygen-related injuries. So also with automated control of oxygenation, the number of manual adjustments is significantly lower. So it allows more time for you and also the nurses to do other things. Yeah.
So allow me to make a summary in bahasa PRICO. Jadi PRICO ini mungkin kalau teman-teman udah pernah mendengar juga ya, sistem namanya Automated Oxygen Loop ya. Jadi dia bisa memberikan feedback ke ventilator, lalu melakukan adjustment ventilatornya menurunkan FiO2 kalau saturasinya sudah melebihi target, atau meningkatkan FiO2 kalau saturasinya di bawah target. Nah, ini seperti Clio ya di Avea ya, boleh disebut karena sama jual. Jadi beberapa kita selalu berasa kalau pakai oxygen loop ini nanti membahayakan. Kenapa? Karena begitu pasiennya ada perburukan, saturasi akan dijaga baik karena kita meningkatkan FiO2 gitu kan. Keengganan untuk menggunakan closed loop oxygen sistem ini seperti itu. Tapi sebenarnya di sini ada sistem alarm. Alarmnya kita bisa set nanti. Yang penting alarmnya nyala. Begitu alarmnya nyala, oh ternyata FiO2 yang diberikan sudah tinggi. Misalkan kita set berapa? 40, 50, 60 sebagai tanda bahaya ya. Nanti kita harus mengecek pasiennya. Mungkin ETT-nya king, mungkin parunya kolaps ya, mungkin sekretnya banyak dan sebagainya. Pneumotorak atau sebagainya. Nah, sistem PRICO ini sangat baik untuk lebih bagus lagi untuk mencegah over oksigenasi. Jadi oksigennya kebanyakan. Nah, jadi kita kan sering tuh kalau pasiennya bagus, saturasi SpO2 100. Nah, itu akan bahaya bagi bayinya. Jadi akan turunkan otomatis. Itu aja sih, nggak terlalu banyak seperti tadi ya FOT ya resumenya. Terima kasih. Dokter Brigita ada pertanyaan? Mungkin sebelum istirahat.
Thank you. I still confused because I'm not yet applicate the PRICO. My first question is we use PRICO in non-invasive and invasive. Can we use the PRICO in the delivery room maybe? first question.
So, sorry, can you use PRICO
in delivery room?
what?
In delivery room. Maybe we can use this tool
In delivery room. Yes. Actually, if you have the ventilator in delivery room, yeah, you can use. Yes. So if you already intubated the patient in the delivery room, you have the ventilator there, you'll be able to connect to the patient and you can put on the probe and the PRICO will go on from there. Yeah. So depends on if the patient is intubated or not, or if you have started NIV. Yeah, so once you hook onto NIV or intubated patients on the ventilator, you set up the PRICO with the SpO2 probe. Yeah, you can use the PRICO in the delivery room. Yeah, no problem.
So if I'm not wrong, we can use this PRICO in the ventilator, maybe something like ventilatory transport from the delivery room until we
to go to
the NICU.
Yes. Okay. So for the transport wise, if you have the compressor and also oxygen tank, this one will need might be difficult because we will need additional battery also as well. Yeah, to move from the delivery room to the patient. But if you have the oxygen tanks, you'll be able to move it out. Yeah, and also the air tanks. Then you can just move the patient, transport on them. Yeah.
Okay, thank you. The second question is, before we use the PRICO, we should set the lower or the higher oxygen level that we must pay attention that.
Okay, so here let's look at the settings here on. Can you see, right? Okay. Yeah, okay. So on the PRICO here, right, you will set what you want as the low SpO2 target and then what you want as the high SpO2 target. So if you are looking at the screen, let me show you here. So this one is the low SpO2 target, okay? So they set it at 80. And then for this one, high SpO2 target 95%. Okay, but of course, based on your hospital protocol, you can set from 90 to 95 or 88 to 92, whichever that you want to set. Yeah, you can set the target that you want here. And then what is the FiO2 that you allow the ventilator to automatically titrate the FiO2 to. So later on, if you see that this example here, patient's SpO2 is at 83, right? So it's outside the target that you have set. So currently, maybe the FiO2 that is given to the patient maybe is around 30. Yeah, the ventilator will increase the FiO2 up to 50 to try to make sure that the patient's SpO2 goes into 80 to 95. So, but now 83 is okay because it's within the range. Sorry. Yeah, so 83 is within the range. Yeah, so the ventilator will not keep adjusting the FiO2. But if 83 is outside the range, then the ventilator will adjust the FiO2 based on this 25% to 50% that you have set. So depending on patients, you might want to be more careful. Then maybe you can set 25 to 40%. But some patients, you think that, this patient is a long-term patient, it's quite safe, you want to go up to 60, you can also set from 25 to 60, that's fine also. So depending on what you feel is good for the patient, you set the FiO2 that you want the ventilator to automatically titrate the FiO2 for the patient.
Okay, thank you.
Yeah, welcome. Yes.
What will happen if the baby had shock? If the baby had shock, is there any effect?
If the patient has shock, so which means the perfusion is low, right? So here you can see that we have the perfusion index here. Yeah, and also telling us the signal quality at the side here, there's a signal quality also as well. So the ventilator, if the signal quality is low, it will also tell you that your PRICO might not be working that well. Yeah, so of course in cases that where the baby is in shock, the ventilator, if it doesn't give you the correct good signals, it will inform you to tell you that PRICO, they will either turn off the PRICO or will tell you that the PRICO will not give you accurate results. Yeah.